Talk a little bit about the biology of limb lengthening and its application as it concerns the biology. Well, limb lengthening is not new. Cordivilla first reported about it more than 100 years ago in 1904. And even at that time, he mentions that one has to make efforts to overcome the resistance of muscles. Therefore, even in its very nascent stage, Cordivilla understood the role of the soft tissues, in short, the biology. Very famously, Girdlestone said, "The bone is a plant with its roots in soft tissues. It requires the patient care and understanding of a gardener, and not just the ministrations of a carpenter or a cabinet maker." So, if we look at the history of limb lengthening, the Wagner technique, which ruled the roost before the Ilizarov, really had a lot of complications because it understood absolutely nothing about the biology. As you can see from this chart from Boston Children's Hospital, the slide shows that as many as 7 surgical procedures were required just to get 7 centimeters of lengthening. So the Wagner technique was fraught with complications. So now we have the Ilizarov technique, which has given us limb lengthening with a solid foundation of biological rules. And these 7 golden rules for achieving good regenerated bone formation, 7 secrets as it were, are firstly stable fixation, which is the most important, atraumatic corticotomy, which is done through small incisions, the periosteum is not damaged, and care is taken to ensure that the bony fragments are not displaced. A suitable latency is used, that is in younger children, less number of days, in older patients, more days before the distraction begins, the rate of distraction being no more than a millimeter a day, and then you vary depending upon the etiology. For example, in poliomyelitis, if one has to do lengthening, we would go at a lower rate because of the poor muscle function. And the rhythm of distraction is typically 1/4 millimeter 4 times a day, and that can be varied depending upon how the regenerated bone is behaving. We aim to preserve the vascularity by not damaging the periosteal and, if possible, the endosteal supply. And of course, to preserve the function, that is, the patients are encouraged to walk, move about, and participate in all their activities to ensure improved blood flow and bone. So, coming to fixation, a couple of examples. This is a young lady with shortening of 14 centimeters due to growth arrest due to osteomyelitis. So, we start her humerus lengthening with this LRS fixator. And when we find that the bone formation is not adequate, you can see that in the proximal fragment we have added a 3rd pin. So stability of fixation is something we judge throughout the follow-up period, and we can add to it by adding pins, by adding connections, by adding rings, etc. So she went on to get her 14 centimeters of length and retained elbow function, and bone formed very well without the need for any augmentation. This is a story of the very 3rd patient of ours at our center for whom we lengthened 8 centimeters with in the femur, and we found that during his treatment his connections had all come loose, and to our dismay we found the bone had all but disappeared. And just by tightening and regaining the stability of the frame, we could get back all of the degenerate bone. And here he is 20 years after the surgery with good range of motion after 8 centimeters of lengthening in the frame. Soft tissue resistance plays a great role in limb lengthening. It is dependent upon the percentage lengthening. So if, for example, we are performing lengthening for, as in this young lady who's a doctor's daughter, and we gave her 22 centimeters of length in the lower extremities and 9 centimeters in her humeri. This extent of lengthening is possible only because of the redundantly long muscles in achondroplasia, which do not generate any soft tissue resistance. So we can lengthen her tibia and femur almost to the extent of 50% resistance. Whereas if we perform cosmetic increase of height, stature in a normal person, as in this software engineer from Bengaluru city, we could lengthen 6 centimeters, which was approximately 15 to 16% of his initial tibial length. Any more than that, and we are likely to run into difficulties as a result of soft tissue tension, such as axial deviations, such as joint stiffness, contractures, or subluxations, or dislocations. Etiology plays a great role. Coming to congenital short femur or congenital femoral deficiency, grade 1 in this child, we make it a point to lengthen no more than 3 to 4 centimeters in one stage if we have not performed extensive preparatory surgeries. That's a safe way to ensure that no conditions will develop. And after the lengthening is achieved, we protect the femur region with the help of a flexible nail so that we are rewarded with good function in this child and lesser risk of refracture. Because the soft tissues in congenital femoral deficiency are likely to be abnormal and have less elasticity, not protecting the bone or trying to lengthen too much would likely to result in a non-union or a deformity at the site. We have to look at joint stability before deciding how much to lengthen and before starting to lengthen. Therefore, we have to perform surgeries as well. This is another child with congenital femoral deficiency, and a close-up of her hip shows inadequate acetabular coverage. Before we start the lengthening, we performed a Dega osteotomy to improve the coverage of the acetabulum using fibular grafts and lengthened the tibia at the same time. It's only in the second stage that we went on to lengthen her femur. Tibial lengthening, 3 years lengthening, so that she had good range of knee motion. And she went on to get a second femoral lengthening 4 years after that in order to give her almost equal leg lengths. So surgery in form of stabilizing the hip or the knee or the ankle is a must. One cannot emphasize the need for an atraumatic corticotomy. Corticotomy itself can be performed as a classic corticotomy, which is done in all wire frames, that is directly using the sharp thin osteotome, or a drill hole corticotomy becomes a must when we use half pins for fixation. And a jiggly saw osteotomy is very useful, especially when we have short fragments, such as in performing a bone transport with a small fragment, or it is typically used by us when we are performing a high subphyseal osteotomy for lengthening in children with congenital pseudarthrosis of. What's also important is not to create an initial gap. The X-ray on the left shows that after the corticotomy, the bony fragments are not displaced at all, and therefore we are rewarded with this excellent bone formation, which also shows a minimal intrazone. The corticotomy level itself can be either metaphyseal or diaphyseal. And as I just recently pointed out, in congenital pseudarthrosis of tibia, it's necessary to perform a corticotomy very high in the metaphysis or just subphyseal. One also takes care not to perform a corticotomy in a zone where the skin is of poor quality, or in CPT children where there is trumpeting or cysts which are visible. In general, we would not like to perform a corticotomy in the presence of sclerotic bone or poor soft tissue. So here is another child who was not operated upon by us, operated upon by a famous pediatric orthopedic surgeon, who ended up with a pseudarthrosis of his corticotomy site, because you can see that the corticotomy has been performed very, very distally in the diaphysis. And the child had a harrowing experience and chose not to undergo any further treatment for a really long time. In congenital femoral deficiency, as I was pointing out, if the corticotomy is performed in the mid shaft as was done for this child, the narrow bone at that level gives very poor regenerate, as well as the excessive soft tissue tension, because no preparatory surgeries and soft tissue releases have been done, was responsible for this non-union as well as this severe varus and procurvatum deformity with a non-union. Go down and perform a fixation, not only of his femur but also of his tibia, to ensure that we could just get him to unite, an act which itself took 3 to 4 months of fixation, like so. Or a corticotomy performed at the level of the apex of this very large deformity in posteromedial bowing of the tibia gave us poor regenerate bone, not only because it was done mid-diaphysis, but also because the child became chesty in the evening of the surgery and a pediatrician was called, prescribed, and gave steroids. So, NSAIDs and steroids can adversely affect regenerate bone formation, as can the site of the cells. So, we salvaged this situation by performing a bone grafting and give him a completely. When he came to us 5 years after the first surgery, the second surgery was performed through the upper metaphysis, which gave rise to excellent bone formation without any problems whatsoever. The location of the corticotomy is very important. This young lady has got forearm shortening and discrepancy between the radius and ulna. So we choose to put lengthening in the distal metaphysis, the broad bone, and in the ulna, in the proximal metaphysis, where the bony surfaces are large, and one is likely to get good bone formation, as you can see on the X-ray on the. So she was rewarded with excellent bone formation, which did not take too long. We could reconstitute a radioulnar joint and make them equal, so she could retain all of her forearm. So smoking, NSAIDs, steroids, radiation, and chemotherapy can all adversely affect bone formation. Now let us address the question of when to, that is, at what age. We know from the work of Professor Simpson and from this paper from Semmelweis University in Hungary that young muscles respond very well to lengthening, and a large amount of lengthening is possible before the muscles as well as the tendons. So the muscles and tendons, which can be a major source of resistance, are more compliant in younger children, and hence lengthening in younger children, which we recognize in this 15-month-old boy with posteromedial bowing of the tibia. We could easily lengthen him. The fixator was well tolerated. The procedure went without a hitch. The treatment duration was small and very well and quickly. Let us address the question of how much to lengthen. So when this young lad presented to us with femoral and tibial shortening due to congenital reasons, and we lengthened his femur and his tibia, since the bone formation was good, we chose to over lengthen a little bit, which resulted in this apparent posture of flexion in the knee at the end of the surgery. Rewarded when he grew up with a very small amount of residual shortening, even though he has congenital femoral deficiency grade 1 or possibly a fibular hemimelia with a ball and socket ankle, as you can see. So he had a second stage lengthening when he was 17 years of age with this TSF fixator, and a small lengthening was needed without many problems. Sometimes it's important when not to lengthen and when. So if your patient is immobile, cannot ambulate, cannot walk, if they're uncooperative, or if they're smokers and they cannot give up smoking, or if they find it very difficult to come for follow-up. And in the very beginning of one's experience, in the tough congenital cases, it's better not to lengthen. Let us turn our attention now to which segment. So in this lady who has post-osteomyelitis growth arrest and a bone gap in the lower femur, we have to obviously lengthen the femur to fill up the gap, but this dramatic discrepancy of 33 centimeters also needs that her tibia has to be lengthened even though it's not short, which is what we did. We lengthened her short femur, filled up her gap, and also lengthened to give her 25 centimeters of length in one stage. In the second stage, we will lengthen her femur. There is some interesting work that has come from anthropological data from the paper of Weinberg and Liu that if we over-lengthen the tibia and reverse the ratio of the normal femoral to tibial length, there is a high possibility of arthritis developing in the hip and the knee joints later on, as was discovered in the archaeological findings of cadaveric bone. So where in the bone should so doing a lengthening and a gradual correction like so, we need to perform, of course, the correction at the site of the deformity, and we should perform the correction very gradually. If there is an angular deformity and a rotational deformity as well, we gradually lengthen first in a straight line and then slowly correct the angular deformity, and in the very end correct the rotational deformity, like we did for this young man. And he got all of his correction of the recurvatum deformity, of the varus deformity, and all of his length that he needed. Which is more important, the periosteum? It is now established beyond doubt that the periosteum is the more important of the two, because we have been performing lengthening over IM nails since the last 2 decades very successfully. This young lad had post-osteomyelitis growth arrest, for which we lengthened his femur over a nail by 7 centimeters. And as you can see, the marrow, we know, the marrow circulation regenerates very quickly. The periosteum, however, is the more crucial of the two, and all efforts should be made to. And lengthening over nail, the benefit is that the fixator comes off early, and early knee range of contributed. We can perform lengthening with acute correction of a deformity if we are using intermediary nailing. It's a lengthening over a nail, and in younger people like this adolescent girl, a large deformity can be corrected acutely and lengthened over a nail because the nail provides stability and age is on her side. But we would not do the same if the bone is of poor quality or in much older people. So rotation, if it needs to be done as in this child, would have to be done as a lengthening first and then slow gradual derotation. As you can see in the fixator montage in the lower part of the tibia where the two rings are parallel and the limb is being slowly to give him a normal looking foot which faces forwards again. Sometimes where to lengthen, we can do visualisis. An example, this young lad had congenital pseudarthrosis of tibia. He had first time we did bone transport after resection and of length, but it failed to unite at the non-union site. A second instance of compression also failed to achieve union. Decided that the short distal fragment is the source of the problems, and hence we lengthened it using distraction epiphysiolysis, like so, to increase it to a size of 9 centimeters. And since the pseudarthrosis migrated proximally, it very easily was amenable to compression and use. And this is a 24-year-old follow-up of this gentleman who continues to enjoy a united tibia without any problem. It plays a very important role. And we have found to our dismay in more than 100 post-traumatic femur lengthenings that axial deviation is common in upper femoral lengthening, especially the varus and procurvatum, because of the tight hamstrings and the adductors in older patients. Watch out for it. However, in this gentleman who lost 17 centimeters of his femur in a road traffic accident, because the soft tissues were all intact and there was no lengthen all of the bone without any axial. So we know that the a normotrophic, that is the bone is of normal diameter and is homogeneous and consistent, and this is a ultramicrograph showing the trabeculae are well formed and are uniform. Trophic bone does not form well, as in this lady who distracted wrongly and distracted 1 millimeter 4 times a day to get a very poor bone formation. We could solve the problem by performing the accordion maneuver. That is, we go back in reverse and we stop and then we come forward again and manage to solve the problem and get her bone to unite without the need for bone graft or augmentation, like so. Partial defects are also possible in the bone, which necessitates us to protect the person for a longish time after frame removal so that there can be no refracture. We now have come up with an objective method of analyzing the regenerate bone by the pixel value ratio so that we can remove the frame when the pixel value ratio of the normal to regenerate bone. Hypertrophic bone can often be seen in femur lengthenings, in achondroplasia in younger children. Here are 3 examples of patients who had multiple episodes of premature consolidation in the femur because of the complete envelope of muscles and rich vascularity. So, I would like to end this with a quote from the great jazz musician Wynton Marsalis, who reminds us that technology of the soul has not changed for a long time. Just because our tools have become more advanced, we should not feel that we are more advanced. In the same light, the biology of limb lengthening, the biology and physiology of the human tissues has not changed for a long time, despite the fact that we have new tools like the LRS or the TSF fixator or the fixator assisted nailing or lengthening, lengthening and then nailing, or the fully implantable nails like the precise nail which use external remote control. Lengthening and its biology remain the same, and perhaps lengthening is like jazz, it can be learned, but it cannot be. So in the words of the great Professor Ilizarov, if you do it right, you will have none or fewer complications in lengthening. I thank you for